We're going to be starting now our event on the road to universal healthcare coverage with a word from Anne Huddock, CEO and President of Counterpart International. Anne, if you...
Welcome, everyone. Thanks so much for making time to be here. We are really glad that you could join us, and I'm using the mic because we are recording this. So I wanted to let you know that this will be on video, and so for those who haven't been able to attend, we'll be able to share the link and make sure that they can also benefit from the discussion. This is such an important and timely topic, and this is something that Counterpart has been really committed to in terms of engaging with our community, bringing in our partners who are really working on the ground, and today's event is no exception. And so we're delighted to be able to talk about our inclusive social accountability framework, which we launched as a way of really trying to gather up all the evidence that we had been seeing in our programs over 50 plus years, and thinking about how we can use these approaches in ways that will help us get to access issues, to equity issues, to inclusion issues, things that are just so important for accountability and transparency, which we all know is central to effective development in any sector. But there are a few more important ones than the health sector. It affects all of us, and we've all been grappling with challenges of how do you make sure people have access to the right health care, and how do we make sure that the voices of the marginalized are weighing in on policy reform and engaged in advocacy. And so today we're really privileged to have our partners from Abt and IntraHealth and Methodist Healthcare Ministries, along with Christian Arendel, who will be our moderator, and he's our Senior Director of Governance. So I'm delighted that we can all benefit from these experiences and look forward to hearing from them and from all of you. So let me turn to Christian.
Thank you, Anne. Thank you for coming. We are really excited about this event. We really think this is a very important topic, and this is certainly confirmed by the fact that next week, almost exactly a week from today, there will be a high-level UN meeting in parallel with the UN General Assembly that will be focusing on mobilizing commitments, on bringing unity behind the goal of achieving universal healthcare by 2030. So that is an official goal of the UN system, and of course it is an official sustainable development goal, and it is a very ambitious one. At Counterpart, based on our experience, we fear that such a profound change is really going to require a different way of looking at how we go about delivering health services. If we look at the experience, especially over the past 50 years of health service delivery, there have been incredible achievements in a whole range of issues, on family planning, on under 5 child mortality, on expected age. And these achievements, nonetheless, have come without reaching everyone. If we look today at Africa, you have about half of the children who die under 5 are in Africa. And that number just by itself tells you about the challenge that still lies ahead of us. So we think from experience that one critical condition to achieve the goal is really to build more inclusive and accountable health systems. That's what we call at Counterpart inclusive social accountability. And it's not just about methodologies, about new technology to achieve results. It's really about a different way to look at things. And it's really about also very much ensuring that systems are not just top-down, but they are really built from the ground up. We have 5 building blocks for the inclusive social accountability framework. The first is about operationalizing the local knowledge. what does this mean? I think it's really important in itself, because that means that we, especially health service providers or us as Counterpart, doing our governance and social civil society accountability interventions, we don't come with the knowledge. The knowledge is really already local. We may facilitate that knowledge. We may help local stakeholders understand better about issues and help them generate themselves more knowledge. But what is really important is to make sure that that creation of knowledge helps local stakeholders and helps them achieve their goals and what they want to do. And I think in the health sector, it's particularly challenging because doctors, nurses are all educated people, and what they want to do, typically we tend to see people as the problem, right? We need to change their behavior. And I think our approach is a little different from that. It's not about just changing health behavior, but it's really about empowering people to take care of their own health. The second building block is about strengthening capacity for collective action. You may know that Counterpart is really known for the work we do, strengthening civil society worldwide. I think the point we're trying to make through that building block is it is not just about building individual organizations, but it's really about helping build movements. And it's only when you have sufficient strength behind a movement, when organizations not just work on their own. You have countries where you have very strong leaders of civil society, and yet civil society is incapable of coming together to make things move forward and to promote an agenda for change. So we look both at the individuals, we look at the leaders, we look at the organizations, and we look also at the movement. And that's an important part of our inclusive social accountability framework. The third, and I would say this probably is the heart of ISA, is the idea that we're about forming partnerships. And we're going to have examples today of how partnerships have helped move forward and how they have really made a difference in being able to reach more people with better access to healthcare. And the idea that we don't just support civil society to advocate, to demand, to place demands, but also to be part of the solution through partnerships is a very powerful one. That's an idea that Counterpart has been promoting ever since its birth over 50 years ago. It's been really part of the DNA of Counterpart, and we continue to believe in this approach. The fourth building block is about promoting responsive governance through effective citizen monitoring. This is what we tend to think of as social accountability. It's the systems that allow citizens to monitor service delivery. It's also the government mechanisms that allow evidence-based findings to come back and inform how a system is evolving over time. And finally, the last one I think is pretty obvious. It's learning, adapting, and scaling up. We have many examples of very successful pilots. We have, unfortunately, fewer examples of how systems have been scaled up to really make a difference, not just in one community, two communities, a small region, but really at the national or even more at the regional or broader global level. So that is also very important building block. So this is based, as Anne mentioned, on our experience, on the evidence, on what we've seen in the field as Counterpart. This is not an approach that we've been going about 1, 2, 3, 4, 5, and we follow everything and then we repeat, right? This is not what this is about. And this is why today we wanted to invite a number of partners, of organizations that we know are doing really interesting work. They didn't start out by using Counterpart's inclusive social accountability framework. If I'd be honest, they didn't know about it until we contacted them. And then we started talking about this and make sure that it was relevant for them. And it turned out it was extremely relevant. I think this is something that we all came to understand. And each one of the experiences you're going to hear about today highlights one or more of those building blocks and how they've been able to use them, to use those approaches, those principles. They're also as much principles as approaches to really make some very significant impact in their relative countries. So today we have Hailu Zelelew from Abt Associates. I think Abt is very renowned as an organization that's been working on health systems, on health financing for a very long time. I recall going to Ethiopia a few years back and being exposed to their project working with community-based health insurance. And I was really impressed, not just by the fact that this was an initiative that really helped bring about more inclusivity and help finance health systems, but also because what it meant in terms of building accountability in systems once you started having citizens that have a stake in the health systems. Wayan Vota from IntraHealth is going to talk to us about the experience from IntraHealth about absenteeism, health worker absenteeism. That is something that we as Counterpart have worked on in Niger, but in the education sector, about teacher absenteeism. If the people who are supposed to educate or provide healthcare don't show up, then we can talk about inclusion, we can talk about accountability. So his example also, his experience is also going to be extremely interesting in terms of understanding how those issues of inclusivity and accountability come together to bring better health service delivery. Finally, we're going to come back to the US, a little bit further south on the border with Meg Loomis from the Methodist Health Ministries. And she's going to tell us about the experience with the Juntos group, which is really a consortium of primary care and behavioral health providers that have come together to really provide improved health services to a population that didn't have access to it or didn't have access to quality health services. So those three very different examples, hopefully you'll find there is a link, and that the link is inclusive social accountability. That's in any case our pretension. We think really that changing health systems, making them more inclusive, building a stronger accountability is really critical if we want to go to scale and achieve as lofty and as ambitious goals as providing universal health coverage. So we hope we can make a small contribution. As Anne mentioned, this is going to be filmed. We're going to be trying to share it because we really believe that every experience that is going to be presented today brings a lot, and that we can learn a lot from it as providers, as implementers, whatever our responsibility is. So without any further ado, I'm going to ask Hailu to present us the experience of Abt in Ethiopia.
Thank you very much, Christian, and thank you, Counterparts, for giving us the opportunity. It is a pleasure to be in this panel to share what we learned from our Ethiopia experience on initiating and implementing and scaling up community-based health insurance in Ethiopia. So Ethiopia is found in the eastern part of Africa. The program that I'd like to tell you about is spreading throughout the country. Those purplish and blue colors are where we are implementing, but the program is a national program, and it's spreading very fast. I think in terms of the coverage, the scale-up issue, we'll come back to it, but it's rapidly increasing. Like we started this program, even conceptualization toward this 2009, 2010. I started the pilot only in certain districts in 4 largest regions. And now we covered the largest regions and also urban centers. And we have a total coverage of, in fact, now it's over 19% of Ethiopians and over 19% of the population. And still it's growing very fast. So I don't want to follow strictly the PowerPoint slide. This is more to show you the entire information in terms of where we started and where we are. So maybe to go back and why we introduced or why we helped the government in Ethiopia to introduce community-based health insurances. The government of Ethiopia, with international partners, USAID and others, invested a lot in expanding health service coverage, mainly expansion of primary health care services by constructing and availing health centers throughout the country. To give you that background, around 2000, there were only 200, less than 350 health centers throughout the country. As of now, there are close to 4,000 health centers throughout the country. So the physical coverage of access to health has rapidly grown up. But the challenge, like in early 2000, was health service utilization. Even after the services were closer to the communities, utilization was very low. Only about 1 out of 3 Ethiopians visiting health centers only once a year, which is very far compared to what WHO recommends for each individual to visit at least 2 to 3 times a year, whereas what we are talking is only 1 out of 3 visiting health center or the lowest part of health facility. So one of the challenges the government learned was, one is the quality of the service was not there, and the other is the financial aspect of it. Households were not able to afford to pay. Even if the payment was low, still it was difficult for many households to afford. So government planned to introduce health insurance, and we learned it from different countries. Abt had a project. We were under JSI working on child health project, initially helping more on the health financing part, but later we had it as full-fledged bilateral program. So we helped the government to learn from Africa, Asia, and other countries, but also do feasibility study and develop a program. And the decision was to have 2 types of insurance programs in Ethiopia. Community-based health insurance for the informal sector for 80% of Ethiopians. Ethiopia is a very diverse, rural-based country, so most of the Ethiopians are dependent on the informal sector, more of small-scale agriculture. And social health insurance for the formal sector for about 20% of Ethiopians. The social health insurance is still evolving. It hasn't been started, but the community-based health insurance, as I mentioned, was piloted in 2011 up to 2013. We evaluated that, and then now it is scaled up, and about 5,000 districts in Ethiopia, more than 25% of the country's geography has that coverage. And one important, based on the evaluation, what we learned is when households are insured, health service utilization has substantially improved, like compared to those who don't have those who don't have financial protection. Those who has the financial protection, they use health services by 26% more compared to those who doesn't have the financial protection. Another important result from the community-based health insurance from the pilot is women were very empowered because they have the community-based health insurance cards. They were not waiting for their husbands to go for health service or to take their kids when they are sick. So it was very empowering for women. In terms of linking our experience to the inclusive social accountability, I tried to revisit after we talked about this session and how our approach was palatable to the ISA building blocks. I think in terms of operationalizing local knowledge, we started with community-based health organizations with local administration in terms of sensitizing the community, in terms of making the decision whether to join community-based health insurance or not. That is based on the local structure, local community-based health, community-based and also religious organization. And also later when we introduced the program, government provided protection for the poorest segment of the population by paying their contribution directly. So the selection was made by the communities themselves in the villages because they know in the community who is poor. So we used the community knowledge, the community structure to select the poorest segments of the population to join the scheme. In terms of local capacity building, we help development of local, at least regional level legislation, which allows the legal recognition of community-based health insurance schemes. But also, we helped government to build their capacity, including government hired 3 community-based health insurance schemes staff in each scheme, which means like for the 13 pilot when we started, government hired 3 professionals for each of the schemes. So there is a community contribution, but government also contributed substantially, including by hiring those 3 staff, by paying their operational budget, and also by paying for the poor. In terms of social partnership, I think the fact that community members were leading these schemes in which local governments were also involved as members of the governing board at district level. This was an important partnership between the community and local government. So we had that experience of developing the social partnership. In terms of responsiveness, I think one important process that has been institutionalized is to have this community-based health insurance and health facility interface, which is on quarterly basis, community-based health insurance schemes assess how their members feel about the service they are getting in the health centers, and on quarterly basis, they meet with health facility. They give feedback, but also they make facilities and providers accountable to the scheme because they are paying, they are organized, and it has improved that responsiveness. And we learned it at least based on ad hoc evidence that the behavior of providers has improved substantially because of this accountability and responsiveness to the community. In terms of learning, adapting, and scale up, I think this is, as Christian mentioned, we have globally, we have immense experience in piloting, especially as NGOs in most cases were good in piloting learning, but scale up is a challenge. The advantage of this program, this is a government-owned program, government community collaboration program. We support technically. So because of that, the scale-up is very big. From 13 districts, now about 500 districts have community-based health insurance. Over 350 of them, they have functioning schemes, which means they are reimbursing facilities, they are entering into contract with health service providers and reimbursing them for the service provided to the schemes. And the remaining over 150 are in the process of establishing. And then it's expanding also even to other districts and regions. So the learning and the scale up is what we approached. We have strong monitoring and evaluation system. We evaluated the pilot program in 2004 when before the scale up. So we learned from the pilot, and the scale up is very impressive. I think, as you can see, maybe from the right side, 82% of the CBHI members are contributors, those who can afford to pay. It's about 240 birr per year, which means about $10 annually, the contribution per household. And for 18%, government is paying. So government is paying for the poorest segments of the population, which is, this program is very inclusive. The poorest of the poor at least are covered under the TBHI program. As you can see from the funnel on the right side, in terms of pooling, resources are coming from 3 sources. One is the contribution from the householders, 2 is targeted subsidy, and the 3rd is general subsidy from government. Government, in addition to paying for targeted subsidy, it's contributing up to 10% for general subsidy to sustain the program. I think in terms of the organizational structure, flow of information, funding, this is how, and also the relation to the providers, this is how it is organized. And what's important at the top of this diagram is there is a general assembly which the community representatives of community members are making the final decision on their community-based health insurance. The board is underneath, which because of government's interest and resource, local government is represented, but the community are the important players at that level. Thank you very much.
Thank you very much. Thank you very much, Hailu. I think there are maybe 2 things. It's a very rich presentation and a very rich experience. But 2 things kind of came out of what you've said to me. One is when you talked about the communities and you say they know in the community who is poor. So building on that local knowledge and not assuming, again, that as outsiders we come with that knowledge is really important and really powerful. And the other one is, I didn't get the quote exactly, but basically saying they are paying, they are organized, so they demand accountability. And so this linkage between having a stake in the system, being collectively organized through an institution like the community-based health insurance has really had a very important impact on accountability. So thanks again for this great presentation. Now I will ask Wayan to tell us about his experience about health worker absenteeism. Thank you. Go ahead.
Thanks. And it was really interesting in reading the Counterpart Inclusive Social Accountability Framework. We started our project in 2010, so years before the framework was evolved. But in reading the framework, it actually made a lot of sense, looking retroactively, that there are, I could see where the insights came from. It fit what we were trying to do really well. So in many health clinics in developing countries, this is the reality. It's what keeps me up at night. It's the concept that a community member goes into a health clinic and there is not a health worker for her. The health worker is absent. So she is there, and sadly, this becomes a norm. I think for any of us, if you went into a health clinic and there wasn't anybody there, you would immediately cause a ruckus, probably try to sue. This is so common in many countries that it's treated as normal. And we set out in 2010 to work with the government of Uganda and USAID to break this, to make sure that this was not the norm in Uganda. So in that sense, our target here were ghost workers. Ghost workers are people who are supposed to be on a duty station who are absent from that duty station. As you were remarking earlier, ghost workers are not just in the health sector, education, agriculture, throughout many countries. We were really lucky that in Uganda, the president actually made it a national point that he wanted to see every government worker at their station. And so we were able to take this and help think through how absenteeism was a problem. And it wasn't just a problem in the sense of expense, though it was expensive. You're paying people and they're not showing up. We did studies and found that everywhere from it was over $2 million per province in DRC. It was $9 million in Dominican Republic, untold millions in Uganda. So in combating ghost workers, you're improving the government's ability to pay for services. At the same time, ghost workers are also a drain on morale. We consider them like vampires, right? Just sucking at the morale, because why do you want to work if your peers don't show up to work? And overall, really looking at it in this inclusive social accountability framework, we look at absenteeism as a social inclusion issue. Where are people most absent? In marginalized and rural communities, in the far distant place that no one wants to go to because there isn't much there. Well, those are the people that are marginalized anyway, and so now you're marginalizing them even more by not having services for them. So one of our aspects here was, how do we increase the social inclusion by reducing absenteeism? And so in that sense, we were really trying to think here how to approach this, but how to approach it collaboratively with the health workers, with the community, in a way that actually makes them feel empowered. So I'm a technologist. I'm the director of digital health, but in this project, we started in the original fashion with pen and paper, or pencil and paper. And the idea is that we worked with the community health workers, with the health workers and the community to do a duty roster to make sure that there was someone on duty, the right person on duty at the right time. And that could be, whether it is a frontline health worker as a OGBYN or just a primary care person, and then codified this in technology, so then made a digital timesheet. And timesheets are one thing, but how do you know that if the health worker is actually at their duty station? Well, we instituted biometric identification, in this sense, a fingerprint reader. And the fingerprint reader and the duty rosters were not just for the frontline health worker. They were for the staff at the district level, at the Ministry of Health level. So even the Ministry of Health workers sign in. Actually, it's really interesting going in Uganda. I noticed at the airport they have to sign in. At the Ministry of Health they signed in. At the Ministry of Education they signed in. And so this idea wasn't just, the people that we have to worry about are out in the field, but everybody. And if you're at the Ministry of Health and you're expected to go to different health clinics to check on them, you have to sign in at that health clinic. So in this way, it's really bringing a sense of accountability to every level of the ministry's staff. And then we took all this data, this attendance data and this duty roster data, and put it into IRIS. That's our health information system for the Ministry of Health. And in this, it tracks all the health workers. And so here, you had a system that is tracking health workers in the sense of their professional status, their training, their duty station, their attendance. So now you can see this holistic viewpoint of the health worker. Great. So what does all that really mean? Well, it means this. You could see a map of Uganda, and you can tell the absenteeism rate in each district. And what I love about this is if you look at that upper left and then compare it to the bottom right, you see that there's actually a huge increase in the number of health workers that are on duty station. In fact, through this process, Uganda was able to hire 7,200 new health workers. So really being able to make sure people were on duty and add to the duty, or add to the workers there. So really proud of the progress that Uganda is able to make sure that health workers are actually there. This is a local innovation. I mean, you were talking earlier about the community really knowing. Like you said, they know who the poor people are. Well, this piece of paper, I went to a community health clinic, a district health facility, and I asked them, so do you know who's working at your health facilities today? I mean, what are your reports? And sometimes when you ask this question, they say, oh, right, and they have to go filing in the filing cabinets, or they ask somebody who goes and gets a report. Here the person said, oh, yes, I do, and pulled like the third sheet of paper off her desk and gave it to me. And this was the record of who was or was not on duty that month in that district in Uganda. And I think the text is too small at this resolution, but the first line is, there were 7 people who were not on duty for more than 40% of the time. 4 of those people will be called in front of the tribunal, in essence, to ask them what they were doing. Why weren't they on station? Other people have already left, as in they're no longer in employ. So in that sense, it was really powerful to me that the health system knew exactly who was on duty and were holding people accountable for not showing up. Which, I mean, I think that's a pretty powerful concept, right? And these are health clinics where the district managers cannot go out to check on them. They're very far away. But here they were able to know every month who was on duty and who wasn't, which to me is just a really powerful driver at that facility level. Because this is really what we want to get to, right? Not a ghost worker, but we want to have people on duty are able to take care of the community, and really in a social inclusion way, everybody in the community, and a social accountability way, make sure that the community and the government know that everybody who's supposed to be there is there. So thank you.
Thank you so much, Wayan. I think a lot of really great content and insights in this presentation, starting with the first slide. I think very, very striking slide, and the fact that the lack of service, not having someone show up is just normal. And how do you build accountability when you have no expectation of actual accountability, of actual service being provided? That's obviously a very, very important challenge. And the other takeaway from your presentation, I think, is where are people absent? It's not, and that's really, it goes to the heart of the challenge of universal health coverage, because in the cities, in the more affluent areas, it's not difficult to get there. It's the easy part. But in the rural areas, in the more remote areas, in the areas that don't have the resources, that's where the challenge really is. And that's where the health workers don't show up.
Right.
Yeah. So, and the third element I would say that I thought was very true and very striking, and certainly is in line with Counterpart's experience, is the fact that if everybody is accountable, it's not accountable, nobody is accountable. And this idea that accountability has to be at all levels, and that you don't just expect the people who get the lowest pay typically to be the most accountable, then you have a problem. So thank you so much. Now we're going to change continent. We're in Africa for the first two presentations, and it's really a pleasure to show out those issues. We really wanted Meg to be with us today, because that experience also talks to us about the challenges of inclusion and accountability in the US. And I think we're all aware of the health challenges in this country, and we have people who do great work, and we support through Counterpart the work that is being done by the Juntos consortium. So we're very happy to have Meg Loomis today to talk to us about her experience.
Hopefully I can hold on to my mic for my presentation. So thank you, Christian. So again, I also feel the same sense of resonance with the ISA framework now, retrospectively. And I think it really aligns with what the story I want to tell you today. So again, my name is Meg Loomis. I'm the Capacity Building Officer at Methodist Healthcare Ministries. We own the hospital, the Methodist Hospital System in South Texas, serving 76 counties. We're one of the largest healthcare funders in the state of Texas. And our mission is to, in our grant making, is to fund organizations that serve those who are underserved and uninsured, and particularly in the rural areas of Texas. So the project I want to talk to you about today, that we collaborated with Social Sector Accelerator, right, the consulting arm of Counterpart with, was a project called Juntos for Better Health, and Juntos meaning together, which is based in, move forward, the Laredo area of Texas. So this is a very generalized map, but it shows that pink part of the southernmost tip of Texas. The project, Juntos, was targeting people who are uninsured in Webb, Zapata, and Starr County. But Laredo itself, if you take that star in Webb County and just move it due west, that's where Laredo is. And in order to really understand the context of this Juntos for Better Health partnership, you have to understand the history and where Laredo is now as a community and the context. So Laredo is one of the oldest cities in Texas. It is the third largest point of trade for NAFTA in the United States. There are thousands of semis going back and forth every day. And it's situated right on the Rio Grande River, right on the border. and has become a really hotbed of activity for cartels and drug trafficking in the last, I think the uptick was about 25 years ago. So there became a great deal of violence on both sides of the border. And what that means for us today is it's really a focal point of immigration policy, right? So what that means is there are several detention centers located within these counties, both for children and for adults. And it's very heavily militarized. So ICE is incredibly present. All of the local police enforcement have been enhanced. Military contractors, border patrol, state troopers, right? It very much feels like, in certain parts, I can say from personal experience, like a war zone, right? So imagine trying to provide health care in a place that is already particularly impoverished with that social background, right? Where people are really living in fear in general, much less feeling like they can access or be vulnerable about their own health. Another thing that's important about this area is that there are a number of colonias. I think the most concentration of colonias in the state of Texas, colonias being communities that have really been built literally by the residents. So very little infrastructure, not incorporated, no electricity, many times no running water or sewage, right? And so that's really important when it comes to healthcare provision in this area. So we, as a funder, were really excited when we were starting a new initiative partnering with the US government to fund innovative healthcare systems when the community of Laredo, led by the university there, came to us and said, we have a group of healthcare providers who all serve the uninsured who want to do a collaborative project, right? That's like a grant maker's dream. They teed this up for us. And so we funded their project, I'll come back to those guys later, which was, they had a threefold objectives with this. One, they wanted to address the deep healthcare disparities in Laredo, right? High rates of depression, high rates of diabetes, high rates of alcoholism, right? A third of the residents are living below the poverty line. Half the school children are living below the poverty line. And yet there are no providers, right? I think in some parts of those counties, there's one provider for every 7,000 people, and that's primary care, and then the numbers are just as dismal for mental health and behavioral health providers. So they decided that, one, they wanted to build the capacity of those clinics. So they wanted to pay more to bring all of the public health providers more staff, whether it was mental health, pharmacists, whatever was needed by that clinic to be able to serve more people. They also wanted to implement traveling healthcare teams. So folks who would go out where people are, right? Because transportation, like many rural communities, is a huge barrier, plus the fear, right, that's happening, to go out and do assessments and screenings for hypertension, blood sugar levels, all of the indicators of diabetes, as well as depression and quality of life. So they planned to go into, where people are, grocery stores, the colonias themselves, schools, and then refer those folks back to the providers to make sure that they had a real understanding of what going to a clinic was like and matching them with the right clinic for their needs and creating a medical home for them. And then the third thing they wanted to do is once those folks are in there, those medical homes, they wanted to be able to support those that were pre-diabetic and diabetic, right? Diabetes, we know, is a really gnarly disease. It's hard to treat. So to add some special engagement for those patients to help comply with their treatment plans. They called it the compliance unit, not a particularly friendly name, but that's what it's called for the grant purposes. So this is where they wanted to go, right? And we said absolutely, and we funded them to the tune of about $3 million a year. And it only took a few months for there to really be trouble in paradise. They weren't seeing patients. They weren't spending any of the money that we'd given them. And so I'm the capacity building officer, which really means just I get, the problems that arise when you're funding, right? Which is my privilege. And so my team and I met with this consortium, the Juntos Consortium, the leaders of that partnership, to really look at why was this happening, right? And it really chastened us as a funder because we realized these are clinics that have been operating under duress for their entire 20 to 40 year histories, right? no resources, huge demand, no workforce, all the things we know about in healthcare, huge regulatory shifts at all times, a state that already has really low numbers when it comes to things like maternal mortality, and then very little funding, right? So there were constant turf wars, both for grant funding, government dollars, but also for patients themselves, right? So that they could report on that. And so we had really naively given resources and that it only sort of made things worse because they wanted to do all these things, but they couldn't seem to develop the relationships to do them. So what we did was we partnered with Social Sector Accelerator and worked with them to identify what they needed to do to get to the place of trust to be able to develop this very comprehensive, ambitious, collaborative project. And so because we're a funder, we like to have something documented and tangible, right? We like results. But we also knew that there was a softer side to this story. And so what we decided on was a strategic business plan, right? Not a very sexy or trusting sounding sort of product, but we saw it as a means to get them in the room, to have a mutual goal, to have the really difficult conversations that they needed to have. The important thing for my team was that the funder was not in the room, that we were not there, right? Because we know that when the people with the money enter the room, the power dynamics change, no matter how nice I think I am, right? And so Social Sector, Teresa's team, worked with them for well over a year to have many, many facilitated conversations, collective collecting of data, sidebar conversations, to develop what was eventually a beautiful roadmap, not for where they intended to go for this grant, but where they could go in the future. And so these are just the components themselves, right? Like any business plan. But I think the most important part was how they got to this, right? Which was that we knew that we had chosen facilitators who really understood power structures, how to diffuse power, power dynamics, right? Especially in an environment like Laredo. So where they landed was on a much more robust vision for themselves, right? They started to understand that their mission for their organizations was not individual, right? Even their individual organizations could not meet their missions without a collective mission. So the most important thing, other than just doing more, was that they all really understood that their role within making the Laredo community better, right? And so they were infused with this sense of purpose and meaning that they hadn't entered the grant with, right? And it got to the place where they became a lot more ambitious in what they want to seek more money for, right? And the idea of bringing in more collaborators became very palatable to them, right? Where before it wouldn't have been. So now they wanted to add hospitals, even more specialty care. They wanted the compliance unit to be broader in who it reached. And then the most important thing was what we call in the healthcare world, right, the social determinants of health, is really looking specifically through the business plan on how they were going to bring in all the things, particularly around immigration policy, to be able to sort of bypass some of the federal regulations to get people into the door of those clinics, right? They felt empowered to this sort of vision. Yeah, and so what we really, in looking at the ISA building blocks, I think we really worked on a social partnership, but a byproduct of that was that building block 2, right, which was the capacity building for collective action actually became something that was feasible, where before that year of capacity building it hadn't been. So this is, unfortunately I don't have any pictures of the traveling healthcare teams, but this is the staff that would go out into I think they actually ended up seeing, going to over 250 sites over the course of 2 years, and doing assessments on, I think, almost 25,000 people in the span of that time. So that was one of the teams. That's it.
Thanks.
Yeah.
Thank you so much for this really impressive experience. We read every day or see on TV or on the radio, depending on how we get our news fix, about immigration issues and what's taking place on the border. This really brought to life the type of impact it can have on local communities and their ability to access healthcare, which is very difficult, obviously. I think one of the things that I really appreciated about the approach, and we're really happy that Counterpart with the Social Sector Accelerator was able to support this, is the idea that as founder, you're not in the room, and that you provide the space, the facilitation for people to come up with their own solutions for their own plans. And when you've done that, they clearly have increased their dreams, their purpose. They came out of it with a renewed sense of purpose and even bigger ambitions. So that is indeed extremely impressive. So thank you very much for that presentation. Now, before we go and ask for questions from the audience, I'd like first to ask one follow-up question from each of the panel members to provide maybe a little bit more detail on some aspect of the proposal. And then we will be opening up to questions and discussions to our panelists. So I'm going to keep with the order, start with Hailu. I think one of the really impressive aspects of your presentation and of the experience of Abt in Ethiopia is the scaling up part. So do you have any lessons for scaling up? We're all interested in scaling up. I think we're all tired of pilot programs that go nowhere. And so how did you build in the evidence, the learning, to really help that scaling up to actually take place? And are you so far satisfied with the level of scale that it has reached, or do you have ambition to go even further in terms of scale?
Thank you again, Christian. I think this gives me a great opportunity to thank USAID also. This is a long program. It's not a one project, 5 years, 2 years, 3 years achievement. That has took us over 20 years. So USAID has been part of this long process. But also the other important element for scale up is this is one is fully a government supported program. The Ethiopian government is behind it. The Ethiopian government is, as I mentioned, the government worked extensively on increasing access to health services, which initially focused more on availing primary health care closer to the communities, which achieved tremendous progress from that perspective, but also felt that utilization is far behind what is expected. So this is government-owned, led, locally driven program, and Abt is supporting technically in that process. So we're facilitating, helping, and more of working from behind, helping the government and the community to make things happen. And I think the third element, which is the most important one, is the community ownership. Everywhere we start the program, the people are excited about this opportunity, about getting financial protection, about having the say on their life, and also having this encounter with health facilities. And also the word of mouth from the neighbor district or even the far district is about community-based health insurance. So everything worked together in favor of this big program. In terms of our satisfaction, I think as a person who was involved from the very initial discussions and from where we are, it's very satisfactory. It's great, but also we have very many communities which the program hasn't reached so far, and the government's plan is to cover at least 80% of the districts, 80% of the population by 2020, which is very soon, very ambitious. It's difficult to reach that target, I know, but what it shows us is we are behind in terms of achieving our target, ambitious target, which we are glad that government has this target. We are helping that. But overall, we are behind. It's big progress. But I think achieving universal coverage of type of giving financial protection for all will take us quite a while. But with everybody's positive support, including the USAID as a major partner, government and the community, I think we'll be there in maybe a few years.
Do you think 2030 is a realistic goal for Ethiopia, which is very advanced?
2030, I'm sure at least for community-based health insurance, definitely, I think we'll be there, or maybe even sooner. I don't think it will take us to 2030.
That's wonderful news.
Mm-hmm.
Thank you. Wayan, I have one question for you. The presentation you made really looked at how you created a new system to combat absenteeism, and a very effective one. Yet, you did not elaborate very much on the type of change in attitude that this requires, both at the institutional level, but also at the individual level. We know institutions behave in certain ways. Individuals do. They have different incentives that makes them behave in some ways or others, and it's very, very hard. This is one thing that we all work on and that we all face in all of our programs is that how do you bring about change and how do you manage change, and what type of actions do you take to overcome the resistance to change?
Yeah, the resistance to change is always a problem. As a technologist, that's the point of failure of pretty much any technology project that has failed. It's always that people just didn't adopt it. And sometimes as a technologist, you want to blame the user, and well, it's their problem to not adopt it. But in reality, in this activity in Uganda, it was really interesting. We had buy-in both from the very top. So the president of Uganda, Museveni, was very adamant that he wanted health workers to be on duty. We also had buy-in from the actual health worker level, because they wanted their peers to be on duty. They were very annoyed. I mean, imagine going to work and seeing 3 empty desks and knowing they're getting paid anyway. So at that level, they wanted the honest worker to be paid. And then at the managerial level, they didn't have any data. They knew that people weren't showing up, but they didn't know who wasn't showing up unless they went out to actually stand there and look, and that's a very time-intensive process. So giving them the tools, giving the tools to be able to first collaboratively as a team build their roster, and then be able to enforce it on their peers and know that the manager will fire the person who doesn't show up, and that the manager has to clock in as well, right? This accountability went all the way up the chain. This, to me, I think that was helped really shift the cultural mindset. We had the mindset that people are inherently good. They want to show up. They want to earn an honest wage for an honest day's work. And this gave the ability for the people who were doing that to showcase themselves, and the people who were not to be punished. So in that sense, we were very lucky in that our effort was directly in line with what people wanted to see. Granted, the ghost workers weren't so happy, and there's always some pushback there. And that pushback can be political at certain places. But we were very fortunate in the Uganda case that Museveni has a very strong hold in the politics in the country, and he assigned the permanent secretary to report to him they report every quarter on how many workers in the health or the education or civil service in general were showing up to work. So there was some real pressure there on the top end, and then the health workers were proud of it. So we were lucky in that sense that working with what people want to do already is usually your easiest path to get adoption.
That's a very good point. If only that were true of all of our programs, but at the same time, we need to be also working with what people want to do. So
right.
If we don't, we're making life more difficult for ourselves.
And actually, a small little aside there. So I hate timesheets. I hate filling out my timesheets. I don't think there's anybody who enjoys filling out your timesheet.
Yeah.
But at the same time, if you don't fill out your timesheet, you can't bill the client, and if you can't bill the client, you can't get paid. And my company was really quick. They said, if you don't fill out your timesheet, you don't get paid. And I said, really? And then I didn't fill out my timesheet, and they withheld my pay. And I learned very fast that, man, I'm the first person to turn in my timesheet. But this had not been done in Uganda. You could still have a job and not even show up, much less do your timesheet. Once we started instituting that, I don't think there's anybody that enjoys doing their timesheet anywhere in Uganda or here, but they understood the linkage and they love the accountability. And that I think we all can agree on. They're a pain, but we know that if you don't do them or if you don't have work, you don't work, and so you don't get paid.
So you applied your own personal experience.
Oh yeah, there was definitely personal learning in this process.
Excellent, thanks. Meg, I think what you presented is really an outstanding example of a social partnership. And at Counterpart, we talk a lot about social partnership because, as I indicated in the presentation on our inclusive social accountability framework, it's really goes to the heart of what we're trying to do. And we know how difficult it is to form social partnerships, to get them going, to get the stakeholders to continue working together, to make sure they continue fulfilling their purpose and moving toward their vision, the vision that they have for themselves and for the people they serve. So my question is pretty simple. Do you have any lessons for us that we can apply in our work on how we can make that work?
Yes, I do, is the answer. But yes, I think, this collaboration, even today is not perfect and did not land in a perfect place. It's still messy, right, as all of the partnerships and collaborations are. But I think what we learned was a partnership is only as strong as the quality of the leaders that are involved, right? It's really predicated on leaders who are able to, one, create and articulate a mission and then lead people to that mission, right? And this required folks to do 5 organizations, a university, right, who the city government, and then all these different providers to do that individually, and then also collectively to become greater, right, than the sum of its parts. And so I think what is important to any sort of capacity building collaboratively or just for an individual organization is also is just leadership development. And I hate to use that term because it's so trendy and it's sort of like an empty, leadership development can mean so many things. But I think it really is in areas where we work that are under-resourced and under a lot of stress, it's about it really is about taking advantage of why people are there in the first place, right? Because they believe in the mission, or they're there to care, or they're there because they have a family member that's affected, or there's some personal investment in some level, and is able to channel that into something greater, right? The meaning-making piece I saw become very important. And the leadership among Juntos has changed since the beginning of the project. And and they're really in a holding pattern right now because of money and funding. But I see that the players that are probably going to be the most vocal and participatory are those that know their role and those that have strong leaders that are ambitious about making community change, right? So.
Yeah, importance of leadership. Very important conclusion and lesson. Certainly, at Counterpart, we integrate leadership training and strengthening leaders of organizations, and not just as strong leaders, but as strong collaborators who can work with others. Also, one of the approaches that we try to implement. Well, thanks so much. Really, I want to thank our panel for those wonderful contributions. Now we can open it to the room. I think there is a mic. Yes, the mic is there. So, so you can direct your questions to a specific panel member or general question as you desire. So, go ahead.
Thank you so much. My name is Haitham. I'm a recent grad from the School of International Service, American University, and my concentration is exactly this topic, social accountability, mainly in the health sector. So all of us know that social accountability composed of main 3 components, which is information, action, and response. So my first question to all of you, how do you relate your initiatives to these 3 components?
So you said information?
Yeah, information, which is transparency.
Yes.
And then action, it has to be bottom-up action. and then the response, whether from the healthcare provider or from the state. And this drives me to the next question to Wyan. Your initiative is very brilliant and is straightforward and to the point. And I think you put a very straightforward outcome, which is absenteeism. But my question is, especially in the healthcare delivery, how about the quality of healthcare? This is a point. And number two is, how about the utilization? I think these 2 points should be very important in measuring the impact of your brilliant idea. And from my academic experience, I evaluated as part of my research the impact evaluation studies that measure the quality of social accountability interventions pertain to the outcome, healthcare outcomes. So the points that capture my attention were three points. The first one is that most of impact evaluation studies kind of, I don't want to say it failed, but don't shed the light on the scale and the composition of community participation. I think this is very important. Who are participating from the bottom ground? Number two is the elite capture, especially in your project, Hailu, in Ethiopia. You didn't mention that a little bit. If you can just elaborate on that, this is going to be very good for me as well. And the last point is that the indicators, especially in piloting programs, are we using the right indicators to measure the impact of the right, are we using the right indicators to measure the outcome we are supposed or we want to measure? So these are my comments and a couple of questions.
Thank you. Do we have other questions? We can take 2 or 3 at the same time. Yes, Elliot.
Hi, my name is Elliot Mitchell. I work with Counterpart, and in part I oversee our program in Niger that I think Christian had briefly alluded to, and that we work on absenteeism in the educational sector. My question is for Wayan again, and just specifically, I'm wanting to know, is the biometrics that you guys introduced in Uganda, is that the panacea? I mean, has it worked? Has it worked? Has that been the reason it worked, or have you guys had to address the other issues of absenteeism, maybe access to a paycheck or things that would keep a community health worker maybe out in their province or their village remotely, that might otherwise have led to a willing, someone who would be willing to stay in the village but can't for other reasons, maybe outside of their control.
Thank you. Any other questions for now? Maybe we're going to go, that's a number of questions, kind of bundled together. First, maybe quickly about the 3 principles of social accountability, information, action, and response. Anyone wants to respond to this question? Address.
Go for it. I already have 2 lined up.
Yeah, you have your own specific ones.
Yeah, I think these are great comments and also great questions. Regarding information, I think we start, especially when we started community-based health insurance, we started by learning from others, especially for policymakers, expose them to other countries. And then after that, after having the community-based health insurance experience like in Ghana, Uganda, Rwanda, Senegal, even as far as Mexico and some of the Asian countries. And then it was more of taking that to the Ethiopia context and also knowing the community structures, the community culture, the community solidarity systems, and reaching the community with that information, how community-based health insurance would be palatable to the Ethiopia situation, given the health system, the health utilization, the financial risk, and also to what extent it is relevant to the Ethiopia context, given we have other solidarity mechanisms in the country, including whether to use those solidarity mechanisms or to bring in blended type of community organization to lead community-based health insurance. We have two important community-based health insurance community structures in Ethiopia, which are broadly used throughout the country. One is the funeral service collaboration, which is a strong community-based structure. People gather whenever there is funeral. They contribute their resources. That is throughout the country, from north to south, from east to west. Another one is we have grassroots-based fundraising resource pooling mechanism. We call it ECO. People contribute their small resources into the pool, and it rotates from month to month. And they use that small fund for, be it for initial capital to start a small business in the village, or to buy cow, to buy goats and other stuff. So we brought the international experience and information, took that to local condition, and also the primary purpose, whether those two institutions can stretch to accommodate new things. So what we agreed with the community was, yes, we learn from those systems, but based on experience like in Rwanda, better to start a new program. So the final decision, one, whether to establish community-based health insurance based on the information, it's a community decision. The community should make that decision whether to establish community-based health insurance or not. Second is what type of structure, whether to use those institutions or establish anyone. Then the community broadly agreed to establish new institution, but learning from those traditional institutions like the solidarity aspect. So the information sharing and also the action, the bottom-up decision making, and then the policy process was well institutionalized. And I think in terms of response, the interface was important, like the community-based health insurance members having the access to challenge or to interface with health facilities. We know their challenge, but also given their resources, are health facilities providing the service, including availability of health workers, availability of essential drugs and other stuff. So the responsiveness because of this relation has also improved a lot. I think maybe one point on the indicators issue. One of the most important indicators, the quick indicator, is renewal rate. Community-based membership is based on annual renewal. You can have significant turnout initially in terms of enrollment. Are people renewing their membership? If they renew, it means they have satisfaction from the service they are getting or from the financial protection they are getting. So when we see the renewal rate from our assessment, renewal rate is great compared to some African countries also with community-based health insurance. And then the coverage and other issues I mentioned in terms of population coverage. These are numbers, factors, and great indicators. And when we see that progressing well from year to year, I think that is a great indicator. I think.
Thank you. Thank you. Meg, do you have any comments, maybe beyond the information?
I think I'm stuck on the information stage of that, because I think what we saw, and again, I saw from the outside, was that what really helped unleash the group's ability to really start drafting a business plan with Social Sector Accelerator was when they really started sharing their data and their budgets and really intimate organizational things you don't normally lay on the table, right? So again, they had to get to a state of trust. Again, it wasn't perfect. There wasn't not some hemming and hawing about it, but there was an understanding of the dissonance between we want to get here, but we're not willing to do these steps, right? And so that Social Sector Accelerator was able to close those gaps of information sharing among each other. The worst information sharer among that entire group was us, the funder. And what was really good was that through developing this new level of trust and sort of shared power with each other, they were able to point that out to us quite readily, which was a wonderful byproduct of the whole process, right? Was to call us on our accountability to the process as much as they were having to call each other accountable. And I think that was a result of their having gone through this year-long process together. So it's good.
Thank you. And as a funder, what type of indicators are you looking at?
To clarify, like as far as
Of success.
of course. Well, I will say that there was actually, while all of this was happening, they were also doing a randomized control trial of some of their patients, right? So the other part of this is that we had partnered with, through the Social Innovation Fund, which is a special funding initiative that no longer exists under this administration, but that we got back in 2014, they had to go through very strict research to prove the innovation that we were funding. And so there were very strict indicators as part of that, right? Lowered blood pressure, better depression scores, things like that. But what I think the indicator, and so they evaluated several things involved, mainly the compliance unit. I'm digressing a little bit, but I think, so there was those sorts of indicators that the funders like to have, the hard data, right? Then there was the more qualitative pieces, which was just that we knew that some of these partners who would really pain them to have conversations with each other were getting together on their own or having hard conversations outside of the group or calling us to say, hey, we've been transparent about this, why you funder? So I think that piece of the empowerment was a really big indicator that we've done something successful, because you don't do that unless you feel like you're part of a collective that can push back together, right? So.
Thank you. Wayan, you have a few questions to
deal
with?
I'm going to focus on the quality and utilization. I think it's a great question. Like, to us, the way we looked at it, that the denominator, the start is they have to be present. If your health worker isn't present, there is no quality. If the health worker isn't present, there's zero utilization. So we were really looking at our effort as starting that baseline, starting the ability to have quality and have utilization. And right now we're doing a machine learning pilot to dig into the data. Uganda is nice in that it has a lot of open data from DHS2, from the government, from surveys. And we're really, at this point, trying to figure out, of the 1,200 indicators that we've been able to collect so far, which ones really matter. And so far it looks like about 38 of 1,200 are determining whether people go, whether they get a quality service, because that is something we really are focused on, and what is that outcome. And of course, our goal is to improve the overall health of the Ugandan citizenry as a whole, and that's the end goal. And so it's really interesting now, looking at all these data points, which ones are actually indicative and which ones people are collecting. You're just wondering why. But we'll see. We're still in the very early stages of that. We just, at this point, have been able to figure out which indicators seem to matter, and we haven't yet gone through the validation process to make sure those indicators are actually showing us something versus just, a number that doesn't matter to us. And then on the biometrics, I like the concept, is it a panacea? No technology is a panacea, dear God. But they all help. And so the way we looked at the biometrics and the way they've been able to work with it is they see the biometrics as helping them identify where the problems are. Before the biometric system, or before essentially the attendance process, which biometrics is one part of, before the attendance process, they knew that people weren't showing up. They just didn't know where those people weren't showing up. Now they can say, aha, in our district, this health center has poor attendance records. Why? And now they can go out and they can say, oh, because there's nowhere for the person to live, and so they're having to commute in, or the facility itself is in disrepair, or the community is rejecting the person, or for what other reason. Then they can go deeper and find that underlying reason, because the attendance system isn't the reason. It is merely the indicator to help you figure out what the reason might be. But it is kind of interesting. We did a study of community health workers in Uganda. So these aren't staff people. These are nominally volunteers. But like most community health systems, they receive a lot of benefits. And we did an interesting mapping of who was getting what. Some were getting T-shirts. Some were getting mobile phones. Some were getting mopeds. Or my favorite, some were getting trainings, which they thought of as per diems. So it was really interesting looking into who was getting what, how many things each individual or each class of health worker was getting, and who was giving it to them. Two very interesting findings, I think, from that. First, the government of Uganda gave out the most benefits, more than all the NGOs or donors, which sometimes we have a warped sense that the government does the least. They're actually doing the most. And second, gender wasn't a determinant of who got what. So it wasn't like the men all got the mopeds and the women just got something lesser. What actually it was is where you worked. If you worked in the HIV area, you got a higher level of things that you could consider as benefits than if you worked in WASH. Interesting enough, more women worked in the HIV and more men worked in WASH. So, hey, there was where the gender split went the way that you didn't usually expect it to go. So in that sense, it was really interesting seeing those as the benefits that people were getting. But we want to be able to start linking that to the outcomes, which strangely, of indicators, the tie there wasn't collected so well. So we're still trying to figure on those.
Thank you. And if you had today to make the case for the cost effectiveness of the system you put in place, would that be an easy case to make if you were going to another country and they would say, well, this is too advanced for us, this costs too much money to put this in place?
So it's interesting that sometimes is put forth as a reason why that a government doesn't want to adopt a health worker management information system. But when you start talking about ghost workers and you start talking about the millions of dollars that they know that they are paying to people who are not doing government, who are not providing services, and how much better they could be responsive to the citizenry and get more people excited about government services if they actually had people showing up, that's usually a pretty good conversation starter with a government. And then once you start talking about improving the morale and then all that, that's a bonus. But really, the cost savings, most of the time, we can find way more ghost worker payments than the cost of implementing the system.
Okay. Thank you very much. Do we have other questions? Well, thank you so much for participating, for coming. I think this was really a very interesting panel and very different experiences in different countries, different continents, but that all bring us back to the importance of inclusion, of social accountability, and that hopefully the lessons today can help us all in the work we do learn how to do it better. Certainly I've learned a few things, so I hope you have as well. Thank you.